I think one of the hardest things to get used to is the fact that I'm voting first. I'm always last, so literally. And now Marie, I'm sorry. It's always been me. So anyway, Mr. Calderon, please come forward. AB 1668. Mr. Calderon, the floor is yours.
Thank you, Mr. Chair, and congratulations on your new appointment. Very happy for you.
Congratulations to
you. Mr. Chair and members, today I'm here to present AB 1668, which will allow patients with a terminal illness to seek investigational drugs and treatments under the supervision of a physician in order to try and save their own lives. This bill requires written informed consent by the patients, institutional review board oversight of physician recommendations, and biannual reports to the Department of Public Health to ensure safety for both patients as well as physicians. AB 1668 is simple. If you, your parent, or your child are faced with a terminal illness, then there is a process in place for you to seek potentially life-saving treatments. The bill is substantially similar to AB 159, which I put forth last year. That bill was vetoed by Governor Brown with instructions to give the Federal Drug Administration's expedited compassionate use program a chance to work. However, the new streamlined FDA compassionate use application is still yet not in use. Meanwhile, terminally ill patients are still waiting months to gain access to investigational drugs and treatments. Colleagues, terminally ill patients do not have the luxury of waiting. We must act now to ensure that they have access to investigational drugs and treatments that may save their lives. I urge you to vote yes on this important measure today, and at this time, I would like to introduce Mike DiBartoli and allow him just a moment of time to share his story.
Thank you, Mr. Calderon. Please.
Thank you. Good afternoon. My name is Mike DiBartoli. I lived in California for most of my life, and I served the people of California as a firefighter for the past 28 years. Unfortunately, just over 3.5 years ago, I was diagnosed with a fatal disease. I was at work at the fire station one day, and I had cramps in my left hand, which is sometimes normal, as I thought I was just dehydrated. When the cramps didn't go away, I went to see my primary care physician, and she referred me to a neurologist at UC Davis Medical Center in Sacramento, who did many tests on me, and after a few months, diagnosed me with amyotrophic lateral sclerosis. ALS is a neurological disease that affects the nerves from the brain to the muscles in your body. Approximately 30,000 people in the United States have ALS. There's no cause, treatment, or cure. It is 100% fatal. Most ALS patients die after brain muscles succumb to the disease, and they literally suffocate. 90% of the patients die within 2 to 5 years. My doctor then told me to go home and get my affairs in order. I still don't know what that means. I asked him, when is there going to be a cure? And he said it's a matter of time and money. He told me there's a possibility that I could get enrolled in a clinical trial to assess the value of experimental medications. I came to the conclusion that even if the medication did help me, at least my participation in a drug trial will help others battling the disease. Unfortunately, the UC Davis Clinic was not participating in any current trials involving ALS patients. I was then referred to Stanford Medical Center Neurology Department to inquire whether they were doing any trials. They said they were involved in many clinical trials, but I didn't meet any of the drug company's criteria. I was told I was too old, too healthy, or had the disease for too long. Being disappointed again, I looked to other alternatives. Up to this point, it had been 1.5 years since I was diagnosed. I was running out of time. During an ALS benefit walk, I met others that were afflicted with ALS, and they referred me to Forbes Norris ALS Clinic in San Francisco. After their initial exam, they confirmed my diagnosis and told me that they do participate in clinical trials. Within the next 6 months, we looked for experimental medication that I qualified for. Fortunately, a drug called Tiraceptive, created by a company called Cytokinetics, was looking for participants for their Phase 3 clinical trial. It had already taken several years for this drug to get to Phase 3. The drug works by giving short bursts of strength to the affected muscles, lasting only for a short period, approximately 9 months. The results of the study will conclude approximately a year from now. If successful, it will be submitted to the FDA, and I'm sure the review and approval will take several more years. Up to this point, it's taken 7 years to get to this trial. While getting in this study was a small victory for me and my wife, I don't know if I'm getting the actual medication since it's a double-blind study, and I could be getting a placebo. After my trial concludes at the end of this year, even if the trial is successful and helps me, I won't have access to the drug any longer. It still needs to go through the FDA approval. I have a good friend that was diagnosed with ALS after me, and I referred him to Forbes Norris. He's progressing much more quickly than me. He already has lost his ability to walk, feed himself, speak well, and breathe. His breathing is down to 45% of normal lung capacity. He can't find any trials that he qualifies for or that will accept him. He has lost all hope. ALS affects people in different ways. My disease started in my left hand. Now I have almost no use of either hand, and my arms are very weak, and I'm beginning to lose my balance. A few weeks ago, I fell on the sidewalk and broke a few ribs because I'm unable to catch myself when I fall. Eventually, I have trouble with my throat, and I won't be able to swallow, talk, or breathe. As a firefighter, I used to carry people during rescue operations. Now I can barely carry a cup of coffee. I used to pull fire hoses into burning buildings. Now my wife pulls the covers over me at night. As a captain, I used to give instructions to my crews to protect life and safety. Now I won't be able to tell them I love them. I strongly ask for your support. Fatal diseases do not discriminate against any demographic. It can affect a good Republican like me or a good Democrat like my friend Ian Calderon. Thank you.
Thank you. Thank you very much.
Thank you, Mr. Chairman, members of the committee. My name is Kurt Altman. I was before this committee a couple times at the invitation of Assemblymember Calderon last year, and I appreciate his leadership and his invitation to ask me back this year. As you heard, AB 1668, you heard what it does. Assemblymember Calderon has explained it very well. I'm really here to let you know again that over the last 2.5 years now, I've been to about 30 states, testified to committees like this in about 30 states, am able to answer questions that this committee may have about any potential downfalls or criticisms of bills like this. Currently, right to try laws like AB 1668 are signed into law in 24 states. This year, their law, this year, the bills are running again around the country in approximately 17 to 20. Already this session around the nation, there are 2 bills that have passed assemblies or legislatures and are on their way to the governor in both Georgia and Idaho, and I've been to about 16 more states this year. So, again, to explain, right to try, or AB 1668, has built-in protections. As you heard, it allows terminally ill patients that have no other option, that are ineligible to get into a clinical trial, the ability to access investigational new drugs that their doctor, as a last resort, believes may help them. Some of those protections, again, are the drug has had to have passed phase 1 of the FDA clinical trial, but more importantly, has to remain in clinical testing in phase 2 or phase 3. The other protection that Assemblymember Calderon talked about is that the patient, to be eligible, has to be ineligible for a clinical trial. In other words, this is not designed to take patients away from very important clinical trials that this committee heard about in earlier bills today. This is designed for those 97% approximately of people that are ineligible for any kind of trial as a last resort with the recommendation of their doctor. With that said, I am mindful of this committee's time. Again, I am available to answer any questions that you may have. Because of my travels around the country, I think I should be able to answer most of them. And again, I appreciate your time and consideration of this bill again this year, and ask you to respectfully vote aye. Thank you.
Thank you very much. Additional witnesses in support?
Kelly Brooks on behalf of the Los Angeles County Board of Supervisors. We're here in support of AB 1668 today. The county believes that terminally ill patients that have exhausted all treatment options should deserve the right to experimental treatments that could improve or prolong their lives.
Move the bill. So we have a motion and a second. Any other witnesses in support? Seeing none. Witnesses in opposition? Seeing none. Questions from the committee? Comments? I'm sorry. I was a little quick on the draw. Sorry.
Mr. Chair, thank you.
Thank you. No problem.
It's been an interesting hearing so far. Stephanie Roberson on behalf of the California Nurses Association, here in opposition to AB 1668. Members, there's nothing in this legislation or any bill that's passed on the subject that impacts the availability of drugs to the terminally ill unless the manufacturers of the drugs allow it to be used in advance of FDA approval. There are so many reasons why drug manufacturers don't make their drugs available for compassionate use. It could be regulatory, it could be administrative, but only 86 of the over 32,000 studies enrolling new participants were available for expanded use. I'm not making excuses for the manufacturers, but there must be industry participation. Also, manufacturers are not exempted from FDA rules just because states enact legislation asserting the citizens have the right. It is unfortunate that the bill provides, although I will say very well intentioned, that this bill provides a false sense of hope for patients. And it upsets us to see that the root of the problem is going unchecked. We need to be taking on the cost of drugs and challenging manufacturers that charge excessive prices for all consumers in California. High-priced drugs, specialty drugs will continue to be a barrier for most patients in California. The bill is also premature. On February 4th, as was mentioned earlier, the FDA released new guidance on expanded use and streamlining its efforts to cut down the time from 100 hours to 45 minutes. The process is still moving forward, and what we understand, that guidance will be wrapped up by the summer. So we want to continue to fight for, the right to access to affordable drugs. We want to fight alongside these patients to make sure that they get access to these drugs in a timely manner. And with that, we unfortunately have to oppose this bill. Thank you.
Thank you very much. Anybody else in opposition? Any other witnesses? Okay, seeing none. Questions? Ms. Burke.
I don't have as much of a question. First, I just want to thank Mr. Calderon for bringing this back. From the time you had this here last year to the time till now, I had a friend who wanted to try an investigational drug and unfortunately has since passed. So I have a great understanding of the urgency. Obviously, manufacturer participation is a must, and hopefully that's coming up next on your list of things to do. But in the meantime, I would like to be added as a co-author if you would have me.
Ms. Bonilla.
Thank you for bringing this bill back. I just wanted to say that last year in BMP we added some amendments that just created better safety for the patient, and I'm very happy to support this bill, and glad to see that hopefully it'll be moving forward.
Mr. Chair. Oh, go ahead.
Thank you, Mr. Chair. I too, as a co-author, support this bill and supported it last time. I've been following the FDA and how slow it moves, and the patients just don't have that time. This could be a one-shot deal, and their lives are important. And we've got this bureaucracy we have to deal with the FDA. So I'm thankful you're bringing this back.
Mr. Ridley Thomas.
To the author, do you recall if there were any no votes last year in either house on this bill?
I believe there may have been one or two in the Assembly, but it got about 77 votes in the Assembly and unanimous support in the Senate.
Would this be an appropriate, as in AB 159, an appropriate candidate for veto override? Because it seems that this committee and the body has broad support for the proposal, and it's not unrelated to other experimental directives that we've taken in this session and previous sessions. Would you consider that?
Well, I think on the question of being appropriate, yeah, it is appropriate. I think we would like to work with the governor and try and get the governor to sign on, but that is an option that we're going to keep on the table.
And it's a moving target at this point. They haven't substantially changed their position, the administration of the governor.
We're having conversations with the governor's office moving forward. We hope to convince them.
Thank you. Well, best of luck with this bill. Supported it before and supporting it again. Thank you, Mr. Chair.
Thank you, Mr. Ridley Thomas.
Mr. Cooley? Good. Okay. Allow you to go ahead. Let you close if you'd like.
Okay. Members, Mr. Chair, thank you for your time. Mr. DiBartoli, thank you for sharing your story. And obviously there's a need, and all we're trying to do is just provide these patients one more opportunity, or one opportunity to try and swing for the fences, save their own life. I think them more than anyone understand that it's not a guarantee, but so many things in life are not guarantees. And this is just about having hope. This is about having another avenue. I appreciate your time and would respectfully ask for an aye vote.
Great. Well, thank you, Mr. Calderon. The bill does enjoy a do pass recommendation, and I thank you for bringing it back. My hope is that the FDA actually comes out with regulations this summer that will actually make the need for this bill go away. That would be a great outcome, and certainly much faster than a resolution through a bill signing. So I thank you for bringing it forward. The motion is due pass to B and P, or the recommendation is due pass to B and P. We need a motion in a second. We did? Okay, I missed that too. All right. We got a motion in a second. My apologies. Yeah, give me some coffee. Okay. All right, Madam Secretary, please call the roll.
Wood?
Yes.
Wood, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Tababney? Tababney, aye. Cooley? Cooley, aye. Hernandez? Hernandez, aye. Lackey?
Of course.
Lackey, aye. Nazarian? Olson? Patterson? Patterson, aye. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Stein North? Stein North, aye. Thurmond? Thurmond, aye. Waldron? Waldron, aye.
Mr. Calderon, your bill passes 15-0, moves on to B&P. Thank you very much for bringing it forward, and thank you so much for your witnesses to be here today. We appreciate
Thank you,
it.
members.
Thank you. Next up, Mr. Holden. I will note too, for the record, since the bill is not being amended, we can't really add co-authors at this point. So if the bill is amended at some point, then you have an opportunity. So, okay. Mr. Holden, thank you.
Thank you, Mr. Chair. It's a pleasure to be before you today, Chair and members. Before I begin, I want to accept the committee amendments.
Thank you.
Last year, Assembly Bill.
We have a motion and a second. Your pleasure, Mr. Holden.
Thank you. I appreciate the support. This is a bill that's very important. We're having a second time around at it. It is important that we create more opportunities for people to get off of smoking, and this is an opportunity, especially with the passage of the MCO tax, to create additional funding for that opportunity. And it also, what we've been able to do different from last year was to have a hotline installed in this bill that will allow for smokers to call and get information on the types of medication that's available, thereby giving them more options and understanding of what's available to them. And so with that, I respectfully ask for your aye vote.
Okay, thank you. You have witnesses?
Good afternoon, Lindsay Freitas with the American Lung Association here. We're proud co-sponsors of AB 1696, which would ensure Medi-Cal members are receiving the help they need to quit smoking for good. Since 2008, the Lung Association has produced a report called Helping Smokers Quit, which highlights why it is so important that smokers have the help they need to end their nicotine addiction. Helping Smokers Quit not only saves lives by improving one's health immediately, but also helps save money from lower health care costs, increased workplace productivity, and averted premature death. However, in order to realize these benefits, every single smoker needs access to a comprehensive tobacco cessation benefit, and quit smoking treatments must be provided at no cost to be easy to access. As our report indicates, too many states have policies that make it harder for Medi-Cal enrollees to access treatment, like limiting the quit attempts per year and creating certain barriers to access for tobacco cessation coverage. This is particularly disturbing as Medicaid members have higher rates of tobacco use than the general population. The Surgeon General has concluded that today's cigarette is more deadly and addictive than ever, which makes it even more vital for tobacco users to get the help they need to quit for good. AB 1696 ensures that all eligible Medi-Cal members are put into the best possible position to succeed by providing these comprehensive cessation benefits and removing all barriers to this treatment. So we respectfully request your aye vote.
Thank you.
Good afternoon, Mr. Chair and members. Callie Hanft on behalf of the American Heart and American Stroke Association. You've already heard from my colleague why this bill makes necessary changes to Medi-Cal to ensure comprehensive cessation benefit exists for those wanting to quit. So I just want to touch on the additional policies the bill puts forward. Using existing dollars, the bill authorizes the Department of Healthcare Services to enter into an agreement with the Department of Public Health to furnish nicotine replacement therapies to Medi-Cal callers who already this benefit is already covered for them, to be able to get it from the helpline rather than having to go to their pharmacist. It essentially creates one-stop shopping, and we believe is more efficient manner, which we hope will decrease costs and increase cessation amongst our enrollees in Medi-Cal. Additionally, using existing dollars, the Department of Public Health would be able to provide incentives to adult Medi-Cal beneficiaries in order to help motivate them to enroll and participate in evidence-based tobacco cessation treatments. This strategy has been known to be a very effective tool to help influence smokers to quit, and without any additional costs to the Department of Public Health, we believe is a common sense measure. Lastly, the bill asks that the Department of Healthcare Services annually report tobacco use rates among adult enrollees in Medi-Cal managed care programs to be posted annually on its website, which will help us better understand the tobacco usage rates in Medi-Cal and to evaluate whether or not our cessation treatment plans are effective. If you were to try and look up tobacco use rates in Medi-Cal right now, you'd essentially get a different answer from each agency you called, because simply we're not collecting the data and storing it all in one place. Most physicians are already asking these questions of their patients, and electronic health records already have the ability to get the data. So what we're hoping is a reporting tool is the missing piece here, and will be able to help us streamline in order to make a more effective tobacco use cessation. We believe the bill will help in shrinking the $3.5 billion Medi-Cal currently spends every year to treat tobacco-related illnesses and disease. And I ask for your aye vote. Thank you.
Great, thank you. Additional witnesses in support?
Kimberly Chen with the California Pan-Ethnic Health Network. We were pleased to support this measure last year and happy to see it return, and thank Mr. Holden on his leadership on this issue. Tobacco use is particularly high within communities of color, and for those reasons we strongly urge an aye vote. Thank you.
Michelle Gibbons with the County Health Executives Association of California in support.
Kelly Brooks on behalf of the Association of California Healthcare Districts, also here in strong support.
Tim Gibbs with the American Cancer Society Cancer Action Network and a proud co-sponsor.
Tam Ma with Health Access California in support.
Thank you very much. Any witnesses in opposition? Back to, I'm sorry. My apologies. I'm quick. I didn't mean to be that quick. Sorry.
Good afternoon. I'm Jennifer Alley with the California Association of Health Plans. We have 48 public and private organizations that collectively provide health care coverage to 25 million Californians. Our Medi-Cal managed care plans currently provide smoking cessation services to their enrollees. The United States Preventative Task Force and Centers for Disease Control recommendations on smoking cessation policies are not reflected in the bill. Specifically, counseling is part of a successful smoking cessation program, and this bill makes that optional for our enrollees that we purchase and provide care for. And so that additional cost to us, without that, with unlimited smoking equipped temps, will make it very much more expensive for us to cover. The increased costs of the Medi-Cal managed care plans will not be reflected in their rates for 2 years due to the rate setting process. There's always a lag of new costs being covered and included. We're also concerned about the additional and burdensome administrative reporting requirements by requiring health plans to track and monitor smoking rates with their enrollees at the time of enrollment in the plan. Medi-Cal beneficiaries are allowed to change plans on a monthly basis, so the tracking and maintaining that information with a smoking cessation program that doesn't require prior authorizations for medications will become very burdensome for our plans to manage and very expensive. And again, those costs will not be reflected in the rates for 2 years. So for these reasons, we are opposed to the bill at this time.
Okay. Anyone else opposed? Any other testimony in opposition? Okay, seeing none, I'll go ahead and bring it back to the committee for questions and comments. Okay, so there hasn't been a motion in a second. I will give you a moment to close here, but I did have a question, and that is, so the bill's coming back. It was vetoed by the governor based essentially on cost, and now there are some additional costs added to the bill. So do you have a strategy on getting the governor to support this? How are you going to address his veto message?
Well, as I mentioned in my opening statement, we're looking at the reorganization of the MCO tax as a way of generating the type of revenue we believe is appropriate for this type of use. But we also said last year, and we think that it's still a valid argument today, that the more success we have at getting people off of tobacco, off of this narcotic that impacts on their lives and their health, that will be overall a very much a benefit to the health system and cost savings in the long run. And so we believe that these are still valid arguments today, coupled with the fact that there is additional revenue that we can turn to help fund the program.
Well, you will get no objection out of me. You know how my feelings about tobacco. So the motion is, my recommendation is a do pass as amended to appropriations. And we will go ahead and ask the Madam Secretary to call the roll.
Wood?
Yes.
Wood? Aye. Mainshine? Aye. Mainshine, aye. Bonilla? Aye. Bonilla, aye. Burke? Burke, aye. Campos? Aye. Campos, aye. Too. Tababne? Aye. Tababne, aye. Cooley? Aye. Cooley, aye. Hernandez? Aye. Hernandez, aye. Lackey? Aye. Lackey, aye. Nazarian? Olson? Aye. Olson, aye. Patterson? No. Patterson, no. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Aye. Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinnorth? Aye. Steinnorth, aye. Thurmond? Aye. Thurmond, aye. Waldron? Waldron, aye.
Mr. Holden, your bill passes 16-1. You're off to appropriations. Thank you very, very much.
Thank you, Mr. Chair. Mr. Lackey didn't give me an oh yeah, but that's okay. We'll
you still has another chance. You want? Apparently not. Okay. It's reserved. Okay. So our final bill of the afternoon, Mr. Mainshine.